Heart failure talk now. The first case will be by Dr. Srikanth. He's a senior interventional cardiologist at Narayana. He will be presenting a case to set as a primer for further discussion about heart failure management. So whenever, as I think by the time they set the slides, any patient who comes with heart failure who has symptoms or signs of heart failure, the first thing you should do is get a 2D echo done. First, see the ejection fraction, whether the ejection fraction is less than 40% or more than 50%. If it is less than 40%, label it as heart failure with reduced ejection fraction. More than 50%, it is heart failure with preserved ejection fraction. And in between, it's a mid-range ejection fraction. The management of heart failure with reduced ejection fraction, the main therapy is the quadruple therapy. Dr. Bhagirath will be speaking on that. And in patients who have preserved ejection fraction, I think we'll give it to Shri.
Yeah, thank you, Chairpersons. Thank you, Professor Nagaraj Desai, sir. So, a woman aged 51-year-old presents with dyspnea and exertion. Is it a heart failure? So, dyspnea is a very common symptoms. Dyspnea is a very common symptom wherein there is a discomfort of breathing, and that sensation is varying in intensity. So there will be multiple potential interaction between physiological, psychological, social and environmental factors, and that induces different physiological and behavioral responses. So if it occurs over few hours to days, it will be called acute dyspnea, or a chronic when it occurs for more than 4 to 8 weeks. Okay. So it may be a manifestation of the lung disease or cardiovascular disease, anemia. There can be other rarer like neuromuscular disorders, obesity, deconditioning. It can be psychogenic. It can be a systemic illness, or it can be a combination of all of the factors. So when we are assessing the patient, we are going to look at all these aspects and assess what is the cause of dyspnea. So coming to the history. So history-wise, yes, patient is breathless. So is there any component of orthopnea also or not? Is there a paroxysmal nocturnal dyspnea that the patient is waking up in the night because of breathing difficulty, whether she is not able to lie down, or she goes to sleep and wakes up with shortness of breath after 2 hours, and reduced exercise tolerance, fatigue, tiredness, ankle swelling, pedal edema, or inability to do any kind of exercise, and swelling in ankles or in the sacral area, and bendopnea. It's a new term, I'll just discuss. And the other things can be nocturnal cough, wheezing, postprandial satiety, lack of appetite, decline in cognitive function, confusion, especially in the elderly people, and depression, dizziness or syncope. So these are all the history we have to elicit when we are assessing a patient, or that patient who has come with breathing difficulty. So bendopnea is a new terminology, reasonably new terminology. On bending forward at waist for more than 30 seconds, the patient becomes breathless. That can be due to increased intra-abdominal pressure. Yeah, increased intra-abdominal pressure and increase in venous return, and as the intrathoracic pressure increases, the pulmonary vascular resistance increases, and the manifestation of heart failure increases. So this is another considered as an important sign. Bendopnea, when they try to tie their lace or anything, they become breathless. And the other important history will be duration. How long the patient has been breathless. So there can be some medical event after which the patient has developed breathlessness that gives us a clue, etiological clue, why the patient is breathless. Just now we discussed atherosclerotic cardiovascular events. Have it happened in the past, or if there are any risk factors for them, hypertension, diabetes, dyslipidemia, family history, all those things, history has to be elicited. More the number of risk factors, higher a chance of her having a CAD as well as concomitantly heart failure secondary to death. And any history of rheumatic heart disease in the past, any procedures have been done, valvular procedures, interventions. Most of the balloon valvuloplasty in a patient with mitral stenosis, they are reasonably asymptomatic. And if they have been done in the past, if she has received any rheumatic fever prophylaxis, it can be elicited. Recent surgery or travel, okay, this is an important thing. The patient may have had a DVT, pulmonary embolism, and obstetric history. If the patient had any PAH in the past, which is again risk factor for CAD, and any, if the symptoms, of course, this lady is 51-year-old. In a slightly younger lady, I would be taking when was the last delivery and when the symptoms started. Peripartum cardiomyopathy is not very rare. Oncological history, if she has had any, she was treated for any breast cancer or uterine malignancies, or if she is undergoing any therapy in the past or in the present, and when was the last therapy given, what were the drugs used, these can be important components for development of cardiotoxicity secondary to anti-cancer drugs or the radiation therapy. And coming to family history, again CAD as well as heart failure, she could be a part of congenital or familial cardiomyopathies, and other medical history like connective tissue disorders, any joint pains, if she is receiving any drugs which are immunomodulators, can all lead to LV dysfunction. And of course, the most another important factor is the pulmonary problems. Apart from the heart failure, pulmonary conditions can also lead to breathlessness, and if there are any history relating to the pulmonary pathology has to be taken. Any drugs, if she has been taking some drugs and she stopped, or if she has started taking new drugs, or of late we should also take history regarding any new therapies they are trying to do, either for weight loss or some other health related benefits, drinking lot of water, or trying out some like fancy dietary modifications. These are all important things we have to take in history. And if she is a known case of any heart disease, chronic heart disease, if she is compliant with her medication, she stopped any medicines, they are important thing. And of course, we just discussed about the diet. If her appetite is low, it could be a part of the heart failure itself. And how is her sleep? We just discussed about P&D, orthopnea. If her sleep is being disturbed, or the other component we just discussed, sleep apnea, it's another important factor where the patient may come with breathlessness. So coming to the, so this is the overall history we will take, and what are the clues which gives us, these clues give us indication like what should be our next set of tests and how should we be examining. Vitals are very important. Either tachycardia is usually expected in a patient with heart failure, and if there are any bradycardia, ectopics or atrial fibrillation, that gives us a clue. Peripheral pulses, we just discussed now. It's very important to see all the pulses. The patient may be a case of coarctation manifesting in a later stage of her life, or if there can be dissection or tachysus, which may be manifesting as heart failure. So BP, at least once we should have documented in all four limbs, preferably in all four limbs. And JVP, again important aspect. The JVP is elevated, we are looking at a more sicker patient, and if the JVP is normal, we can always do abdominal hepatojugular reflex. If the JVP continues to remain high, or there is a sudden drop or rapid drop, it's important to know that the patient is having heart failure. Respiratory rate, if the patient is very tachypneic, and when you are observing she is tachypneic and when you are not observing she is not tachypneic, so a psychogenic component of breathlessness can always be assessed. Patient is cold, fever, again that could be a reason, and then if she is having cold clammy peripheries, that means we are dealing with a more sicker patient, or we should be more active in sending her to the right place. Saturations. So if the patient is in heart failure and the saturations are lower, we are dealing with a very sick patient. Or if the patient is breathless and she tells saturations are 85 and she is comfortable, probably we are looking at a pulmonary pathology. And of course the weight. It's very important to measure the weight of every patient, and if we have a previous documented weight and if there is any weight gain, that gives us a clue that she is accumulating more water. or she's accumulated fluids, and we know what to do when we see her, assess her. So physical examination, most common thing, anemia, anemia. So if there is any edema, ascites, congenital heart disease clues, any clubbing, cyanosis has to be assessed. Cardiorespiratory examination, cardiomegaly, parasternal heaves, murmurs, additional sounds have to be evaluated. Again, respiratory system gives us a clue. So also assess for breathing pattern, hepatomegaly, ascites, and important to assess thyroid if there are any thyromegaly, or if there are any joint pains or any deformities, which gives us a clue regarding her heart failure. So important signs of heart failure: elevated JVP, third heart sound, summation gallop with third heart sounds, cardiomegaly, apical impulse, hepatojugular reflex, chain stroke respiration. So these are all important parameters. Again, signs of heart failure, these green slides, you can remember, these are all indicators or definite indicators for heart failure. So edema, rails, all this we have already discussed. Narrow pulse pressure, oliguria. So these are the things. Unintentional weight gain of more than 2 kilos or weight loss, fatigue. So how do we investigate? We just heard ECG, very important, basic X-ray, screening echo. Nowadays in the emergency there are echo available which do not give a detailed thing, but we know how to assess the EF and NT-proBNP. Okay, arterial blood gases, pulmonary function test, CT chest, these can all be planned. So very important, ECG, when you look, don't miss, don't miss for any myocardial infarction, ST elevation MI, inferior wall MI, okay, complete heart block, yeah, so look for the complete heart block finds, left bundle branch with complete heart block, left bundle branch block, tachyarrhythmias, VT, hyperkalemia. So these are the things, common things which we have to see in a ECG when we do the analysis. A classical X-ray, it's very important to have an X-ray. I'll just show you one more case. This is a cardiomegaly is there, congestion, increased venous as well as pulmonary arterial congestion, and if the patient has had a ICD or a device for his heart failure, it gives us a clue when we are looking for the first time. Pneumothorax, emphysema, pneumonias, again pneumonias, so pleural effusions, and interstitial lung diseases. So this was a case of my own case last week. Mitral stenosis, we had done a balloon mitral valvotomy, has visited all the pulmonologists. He's having breathlessness, and everybody told you go back to the lung cardiologist. And then we found a large bulla which we could diagnose on the CT, a large bulla on the right side. So this is another case who had a PND, very dramatic. Patient came with, he could not sleep or lie down flat. He was calling his relatives to sleep, and he was done a detailed evaluation. CT calcium score was some 1000, so he was asked for an angiogram. He came for a second opinion. Simple X-ray shows eventration of diaphragm with elevation of diaphragm on the left side, and he had a paralysis of diaphragm as well, and he's undergoing treatment for the same. The next important thing, as we just discussed, echocardiography, very, very important. It will show us the ejection fraction and various other things, mitral regurgitation, diastolic filling pressures, how are they, LV thickness, volumes, all these are very important. Echo is the primary thing. Without echocardiography, it's very difficult to diagnose somebody having heart failure or not. And of course, we just saw ejection fraction, size, PA pressures, LV filling pressures, regurgitations. So additional imaging in the form of stress echo can give us more clue. Global longitudinal strain are another important factor. Even when the LV function is normal, the GLS can be low, and it gives us a clue, and also gives us some clues about etiology, something like amyloidosis, etc. So many a times we may have to do a TE to get more clue. So how do we diagnose? On the basis of ejection fraction, EF less than 40, heart failure with reduced ejection fraction. 41 to 49, either mid-range EF or somebody who has improved EF if the LV function documented was less. If the ejection fraction is more than 50, it is a heart failure with preserved ejection fraction. This is how we classify heart failure based on the ejection fraction. So ultrasound of the lung, another important vital thing in the emergency department. So this is how the first frame shows how the normal ultrasound looks. In a setting of pulmonary edema, you can see the comet tails. Usually our emergency physicians do it, and it gives us a clue whether we are dealing with pneumonia, pleural effusion, or a heart failure. So the next thing is NT-proBNP. Yeah. So that gives us, these are the various, the other side. NT-proBNP more than 300 is considered as a heart failure, more than 125 in an ambulatory patient. In a patient receiving ARNIs, always do NT-proBNP. So nowadays, most of the labs are limiting to NT-proBNP. In a patient receiving sacubitril valsartan, their NT-proBNPs will be the correct ones. BNP will be elevated even in the absence of heart failure. So these are the other, the slides I've shown which are the other reasons why the heart NT-proBNP can be elevated. So many other illnesses where the NT-proBNP can be elevated, multiple systemic diseases. In obesity and increased BMI and pericardial disease, the NT-proBNP, even though the patient may have heart failure, it may be falsely low. So this thing we have to keep in mind. So the other more advanced ones are cardiopulmonary exercise testing, where we don't know, and cardiac MRI, nuclear scans can also be done, CT angiogram, right heart cath. So all this while, I would like to go to the last thing, where it's a universal definition of heart failure, which was published in 21. So we need to know that the patient has signs and symptoms of heart failure are present in the patient, and there is some structural abnormality in the heart in the form of reduction in the ejection fraction, or there is enlargement or stiffness or increased thickness of the ventricles, or increased filling pressures, or some other valvular pathology. With these two, and also there is an increase in the NT-proBNP or some other feature. So these are the things, so we already discussed them. So NT-proBNP will be elevated, or we are doing some other pathologies so to find out this thing. When all of them are present, we call a patient as heart failure. So these are the other heart failure kind of things which may not be heart failure. Most importantly, non-cardiac reasons are renal failure, liver failure, morbid obesity, and respiratory failure, which are other causes of heart failure. So heart failure is dyspnea is a complex thing.
Dr. Srikanth, but I think in the interest of time, could you just finish it off in the next 20 seconds?
Done, sir.
Please.
So dyspnea is a complex interaction between cardiac, lung, neuromuscular, and brain as well. So whenever a patient manifests with breathlessness, it could be multiple reasons, and a heart failure is confirmed when there is signs and symptoms classical of heart failure with some pathology which can be diagnosed in the form of X-ray or echo, where we know that there is some structural abnormality plus an elevated NT-proBNP or some other congestive symptoms. It could be crepitations, it could be clinical, it could be a X-ray, or it could be a cath, or it could be NT-proBNP. In this, when we have all of them, we call a particular patient as having heart failure. Thank you, sir.
Thank you. That was an excellent presentation, combining